Good afternoon. Today I'm going to be discussing radiation dose reduction and cardiac imaging. So our goal today here is to review some of the current Joint Commission requirements as they relate to coronary CTA, as well as going over methods to limit radiation dose reduction in patients undergoing cardiac CT. As you know, several years ago, there were several incidents in California which brought to light some of the issues regarding excessive dose in patients undergoing CT. Specifically, these incidents related to technical issues as well as human error. As a result, there has been a lot of play in the public media as well as oversight committees that want more control and more oversight in the performance of computed tomography. As a response to this, there has been multiple legislation passed, specifically in California and Texas, that deal with radiation and CT. The Senate bill, which became effective in 2012 in California, requires that in every patient report, there must be a dose that is outlined in the patient's medical record. This has resulted in several problems in that we really don't know what these doses mean, nor do we have a standard regarding the dose that should be reported. As a result, the doses that we are presenting, while do provide some information for the patient, it doesn't have any impact with regards to how we are to manage the patients in the future. In addition to the California bill, there's also been a sentinel event alert from the Joint Commission, resulting in us having some education and training, not only just for the technologists who are performing these studies, but also for the physicians and the clinicians who order these studies. Lastly, the Joint Commission really wants some type of centralized performance and quality monitoring. The Joint Commission has recently put out new recommendations, which are going to become effective in 2015, that is going to require the documentation of radiation dose in all patient medical records, as well as mandating annual evaluation of the CT scanner by a medical physicist. Not to mention, the CTs are going to be performed by technologists who have minimal qualifications to perform CT. So there's going to be a component of mandatory training and qualifications for the technologists who perform these examinations. Lastly, the Joint Commission requirements really are mandating that we are going to align with the California CT law. That having been said, when it comes to coronary CT, we are not the biggest offenders as far as absolute dose. If we look at the estimates based upon 2007 data, even at that time, without any of the advances in dose reduction on the CT scanners, our average for a coronary CTA was about 12 millisieverts, which is much less than the 20 millisieverts of multi-phase abdominal and pelvis CT, as well as much lower than PET scans or stress thallium scans, which were upwards of 20 to 25 millisieverts. What is our goals when we do perform coronary CTA, as well as any CT studies that have radiation? What we want to keep in mind is we want the study to be diagnostic while maintaining the lowest radiation exposure to the patient. We really must balance the risks and benefits of the study, so we want the lowest dose, but we don't want the dose so low that we are going to negatively impact our diagnostic capabilities. And what has gotten us into some of the problems with overdosing is there's really no immediate negative impact. The negative impact is really in the future, which is the excess radiation exposure, which is not going to be realized for 10 or 20 years. However, there is a real immediate negative impact from too little radiation because the images are so noisy and non-diagnostic. But when we are developing these radiation dose reduction protocols, we need to understand that it is multifactorial. It involves patient factors such as body habitus and BMI, as well as the technical factors, including education of the technologist, as well as the imaging factors such as your KVP and MAS, which is what we have the most control of as the professionals who build these protocols. When we are building these protocols, we really need to keep in mind the patient risk as well as what is the diagnostic dilemma at hand, and really maximize the protocols and build the protocols for the question at hand as well as the patients we are scanning. So we may have multiple protocols for different question, whether it's a pulmonary vein, a coronary CTA, or a functional study, but also manipulate these studies or protocols based upon the patient age and body habitus. So patients who are smaller and who are younger are going to have different protocols than those patients who have larger BMIs or who are older. And what we want to do is minimize the radiation dose while maximizing the diagnostic potential of the study. But we really need to keep in mind that still the risk to the patient from an individual study is very, very low, which is much less than 1%. That leads to addressing some of the issues that have been posited by the Joint Commission and other regulatory agencies, and that is what should we be reporting in the patient's record? Well, currently there are no recommendations and there is no consensus as to what metric we should produce or be reporting. But the metrics out there are the CTDI, which is the dose of the scanner for an individual protocol that's based upon a phantom, which is presented in milligray, or the dose length product, which takes into account the scan length of the patient for the individual study. This metric can be converted into an effective dose estimate that is millisieverts, so we can compare it to multiple studies and in a more effective manner add it up with the studies that the patient has had sequentially. And when we get these numbers, we really need to understand we don't really know what the individual risk is with them, but we need to keep in mind what the doses, the more dose they have, the greater the risk the patient has. When we are building these studies, we need to keep in mind what are the technical parameters. And these are the parameters that we as professionals can adjust so that we can minimize the exposure to the patient. Each of the vendors have software that can adjust these in real time to minimize the patient radiation risk while maximizing the image quality. And I would suggest that working with the vendors that you have to really understand what their software can do and what are the limitations of the individual software. I will go over some of the limitations with these individual parameters. Things that we think about we can adjust is the MAS as well as the KVP. We can do things and modulate these with dose modulation. We can do patient shielding as well as varying the MAS and KVP based upon retrospective gating, where we can lower the dose throughout the cardiac cycle, or do things such as prospective gating, where we're only turning on the radiation source at certain points in the cardiac cycle. We'll start off first discussing the MAS. So we can adjust the MAS throughout the scan cycle, and this is not just for cardiac imaging, but for all forms of CT, where we can do dose modulation. We can use a topogram as a scout image such that the software that the individual vendors have can look at the density of the tissue and then will estimate the MAS that is needed for the specific tissue density. So throughout the scan, it is raising and lowering the MAS to limit the patient dose. Now, this does have some problems in the larger patients where oftentimes the MAS that is generated for these densities is based upon a reference to a phantom, and the noise that is obtained from that phantom. So larger patients, they actually may have larger doses than your estimate in order to reduce the noise. When we are doing this, we may consider for larger patients using a lower fixed MAS rather than using some type of dose modulation. With dose modulation, as I alluded to, it does vary throughout the cardiac cycle based upon the patient's density and body habitus, such that in body areas that have lower density, such as lung tissue, it will lower the MAS. In areas that have higher density, such as around the shoulders, it will increase the MAS to reduce the noise. Utilizing dose modulation techniques, regardless of the vendor, have been shown to lower the radiation dose of up to 20% compared to studies that don't use that. Now, there are some limitations with dose modulation. This is a particular example of a case where the technologist did the topogram, and we see that the upper portion of the chest is not included on the topogram. So when they chose their area of coverage, what they did is they scanned above this area. This was a study which was being done in a coronary CTA in a pediatric patient who had Kawasaki's disease, and the clinician wanted to include the neck vessels so we could look for any abnormalities in the carotid arteries related to their Kawasaki's disease. So the technologist started the scan above the area of the topogram. What happens when that is done is the software oftentimes will have no frame of reference. So what it will do is just use your reference MAS as the MAS for that portion of the scan. When this is done, for that portion of the scan off the topogram, we do not get any benefit from the dose modulation. So we see in this upper image here, the MAS was 350, which was your reference mass, and compared to the lower images where your MAS was approximately 200, we did not get any dose savings of these upper images, which resulted in an excessive dose of about 30% or so. Aside from adjusting the MAS, we can adjust the KVP. Different vendors have different ways to address this. Alternatively, you can do fixed KVPs based upon the patient's body habitus, such that patients less than a BMI of 20, you can use a KVP of 80. Less than a BMI of 25 or 30, you can use a KVP of 100. And multiple studies have shown that this does not impact the diagnostic quality, but does improve the contrast. And how this improves the contrast is as we lower the KVP, we get lower to the K edge of iodine, so our contrast is maximized. The downside is you may have a little bit more noise in your image, but you can really have a very positive signal-to-noise ratio to really look within the lumen of the vessel to evaluate for any stenosis or any abnormalities. And this has been shown to decrease the radiation exposure to a patient of up to 50% versus your standard study of a KVP of 120. Here's an example of a case where two patients have approximately the same BMI 25. One used a KVP of 100, the other a KVP of 120, and we can clearly see here, while the KVP that used 100, the images look a little bit more noisy versus the KVP of 120, you can clearly see within the vessel the calcified and non-calcified plaque and detect the degree of stenosis of about 30% without any degree of difficulty, and the signal-to-noise ratio has been well maintained. And in the 120, we clearly see the vessels very nicely here, but if we lowered the KVP, we would probably not impact all the diagnostic capabilities. Moving on from that, as we do gated studies, retrospective or prospective gated, we worry about the temporal resolution. The better our temporal resolution, the faster the gantry can spin, the faster we can move the table through, which means we can use a higher pitch and decrease. With the higher pitch, we will get a lower radiation dose. In the older generation scanners, with the slower pitches of much less than 1, our doses were much higher. As a result, we had higher radiation doses. As technology bloomed and we can generate images from a half scan, so 180 degree of rotation of the gantry, that decreased our scan time. We could have a much faster pitch and decrease our radiation dose. So when we do ECG gating with coronary CTA, we think about it in 3 terms. We have prospective gating, we have retrospective gating where the radiation dose is on throughout the entire cardiac cycle, and now because of advances in faster table speed and faster gantry rotation time, we have ultra-fast pitch and pitches of greater than 3, where we can move the patient through in essentially a single heartbeat or less than a single heartbeat, freezing motion, and thereby lowering radiation dose substantially. So I'm going to start off with prospective gating. We are only turning on the radiation dose at a very specific phase of the cardiac cycle, typically in end diastolic or mid-diastolic phase. When we do this, it has some advantages. We substantially lower the radiation dose because it is not on during the systolic phase, and in larger areas of coverage with 128, 256, and 320 detectors, we can actually cover the heart in 1 or 2 beats. It really has reduced the scan time, allowing us to do better and better prospective gating. That's the upside. The downside is if you have variable heart rates or faster heart rates of greater than 70, your ability to do prospective gating diminishes because you will get cardiac motion. In order to limit that, we have been able to do what is called padding, so we will actually do prospective gating for a range of the cardiac cycle, say 50 to 70% of the RR interval, which allows us to reconstruct at different portions of the diastolic phase to limit motion. And by doing these types of things, we've been able to decrease radiation exposure of up to 3.5 times that of a standard coronary CTA. The downside is it's very difficult to address arrhythmias and faster heart rates. Again, with prospective gating, we are turning on the radiation source during the diastolic phase, as we see here, and then during the systolic phase, the radiation source is not turned on, so we're turning it on in selected portions until we cover the whole heart. And as we get more and more detector arrays, we can cover greater portions of the heart or the entire heart without moving the table. This is an example here of a prospectively gated study, which we acquired the entire chest in about 15 seconds in a patient who has had a Gatain procedures. And we see clearly here, we see no misregistration artifacts, and we see nice acquisition of the entire aorta as well as coronary arteries throughout the entire cardiac cycle. And we can clearly see there is no narrowing of the reanastomosis of the coronary arteries, and we see the ascending aorta very well, while lowering the radiation dose. Kind of the next step of prospective gating is ultra-high pitch CT. Pitch is the table speed movement per rotation divided by your collimation. So as we get faster and faster table movement and faster gantry rotation time, we are able to get higher pitches, better temporal resolution, freezing the cardiac cycle. By doing that, we decrease pulsation artifact, decrease cardiac motion, decrease respiratory motion, and we can move the patient through the gantry much quicker, thereby increasing our pitch, decreasing the radiation exposure. The advantages, we can markedly reduce radiation exposure of up to 40% by doing ultra-high pitch. The downside is those patients that have faster heart rates or irregular heart rates cannot undergo ultra-high pitch studies because of the cardiac motion. So here's an example of a pediatric patient where we optimized the study to look for anomalous coronaries because the coronaries could not be visualized on the cardiac echo. While the images are a little bit grainy, we can clearly see the origins of the right coronary artery arising at the level of the right coronary artery cusp and the left main coronary artery arising just above the sinus of Valsalva at the tubular aorta, and clearly see that there is no abnormal course of these coronary arteries. So we optimized the study. Here is their dose protocol sheet by lowering the KVP to 80. So we had a very favorable signal to noise. And we could also lower their MAS very low using dose modulation to approximately 50 here. We were able to get a DLP of 11, which translated into much less than 1 millisievert. This is an example of an adult patient where we did something similarly. We lowered the KVP to 100, a reference MAS of 370, and we used a flash study. So this was acquired in the diastolic phase. They had a very slow heart rate of about 60, and we can clearly see the left main going into the LAD and the right main coronary artery, and we clearly see there is no stenosis or coronary artery calcification. And in this study, we were able to obtain a DLP of about 109, which was less than 3 millisievert study. Another example of how this could be utilized in addition to just the coronaries. Here we were looking at the ascending aorta. This patient had a standard aortic study where there was some pulsation artifact, and it was unclear if they had a ascending aortic dissection. So we repeated the study with an ultra-high pitch protocol, thereby freezing aortic motion, and we can clearly see the pulsation artifact has gone away and there was no dissection. Aside from ultra-high pitch and prospective gating, we can do retrospective gating. This has an upside that we can acquire data throughout the entire cardiac cycle, and then we, after the fact, decide when we're going to reconstruct the data at specific phases of the cardiac cycle. We can either reconstruct at a specific phase or throughout the entire cardiac cycle to get functional data. With retrospective gating, you can either reconstruct using what's called single sector reconstruction. So we use it a single slice or a single level. By doing that, we get more photons, improve the signal to noise ratio, and decrease the noise. The downside is that this requires a much longer scan and is more susceptible with faster heart rates, or use multi-sector reconstruction where we choose data from detectors at multiple points along the heart at the same phase of the cardiac cycle and use that to reconstruct the heart. The downside is you have less detectors that you're acquiring from, and thereby introducing more noise. The upside is it's a faster acquisition and you can limit cardiac motion. Also, with image reconstruction, using retrospective, as I said, you can reconstruct at any phase of the cardiac cycle. With faster or higher heart rates, you can reconstruct at the end systolic phase, about 30% of the cardiac cycle, where you can freeze the right coronary artery, as we see here at the end systolic phase, and we get a very nice look of the right coronary artery throughout its entire course. The downside is this person had a little bit more radiation. But we can also modulate the radiation dose or do ECG dose modulation, where we turn up and down the radiation source throughout the entire cardiac cycle. So we have it at peak source in mid-diastolic phase and turn it down to as low as 4% of the maximum in systolic phase, to allow us to be flexible and get functional data as reconstruct at different phases of the cardiac cycle to improve our diagnostic capability. The upside is we can limit the radiation dose of upwards of 50 to 70% of a pulse-gated study, but still have the flexibility of a retrospectively gated study. Two examples here. This is a standard study done several years ago without your traditional retrospective gated study, where we see very nicely the left main coronary artery giving rise to the circumflex and LAD, and it was approximately 7 millisieverts, but using a retrospective pulse gated, we were able to do in another patient a similar study at 4 millisieverts. We see the left main, the LAD, and the circumflex very nicely. We can add to these lowering KVP and lowering MAS software and hardware that your vendor has available, iterative reconstruction. So what we do, rather than our traditional filtered back projection, we use some type of reconstruction that uses different statistical modeling to remove the noise within the system to allow for a better image quality and diagnostic image quality. And multiple vendors have different ways of approaching the iterative reconstruction, but we have found that there is no difference in the spatial resolution. We can still visualize the data at 12 line pairs per centimeter, but by lowering the MAS and KVP, we can markedly decrease the radiation dose up to 60% while maintaining diagnostic image quality. And this really takes effect when we apply it to patients of different body habitus. So those who have the lower body habitus, we can lower the dose by manipulating the KVP, the MAS, and get upwards of 60% reduction. Even doing it in your larger patients greater than 25 BMI, we can still get a substantial reduction in radiation dose. We need to go the next step other than just manipulating these individual protocols. We need to know when we are lowering these doses, does it really work? So as professionals doing study monitoring, having some type of feedback loop that we continually look at the individual studies, look at the doses of the studies, capture this data to see if the changes we are making are not resulting in more repeated scans, more non-diagnostic scans. And I would suggest setting some type of trigger, whatever your institution would want, whether it's DLP or millisieverts for individual studies. And when these triggers are exceeded with the technologist investigating in real time while the patient is still within the department, still on the scanner. Why was this dose abnormal? Was the wrong protocol chosen? Was it patient factors such as a very large BMI or patient motion? Or is it technical factors such that we manipulated the KVP or MAS to a higher than needed level? And this information then comes back to the physicians, is collected, and then we make incremental changes to our protocols to maximize our diagnostic capabilities while minimizing our radiation dose. Looking at and concluding, radiation dose reduction involves multiple facets in the radiology department, especially as it applies to coronary CTA. We need to take into account patient factors such as their body habitus as well as their heart rates, and applying protocols in real time to these patients that limit the motion, improve the maximum or maximize the diagnostic capabilities while taking advantage of dose reduction abilities such as lowering MAS, lowering KVP, and using ultra-high pitch or prospective gating to minimize the radiation doses in these patients. It's really not just adjusting the technical factors, but applying protocols or adjusting all of the parameters to maximize our diagnostic capabilities. Thank you very much.